Good
Good.
evening.
Okay, let's go ahead and pick up where we left off. So we're at chapter 8.
I don't think the chapter 8 PowerPoint is up.
Let me see here, that is possible. Yes. Oh, there it is. Nope, it's the module wasn't open. There we go. Now it's there.
Thank you.
Okay, chapter 8. So we're going to be taking a look at joints and movement. So, and then we'll be moving into muscles. Okay. So let's go ahead and kind of sketch things out first of all. So we'll be taking a look at sort of the confluence between joints and muscles. And there's several different joints we're going to be taking a look at. First of all, we're going to be taking a look at what's called fibrous joints, typically a fairly structural type of a joint. And then we'll look at cartilaginous joints, typically joints that, well, as they say, involve a fair amount of cartilage in them. And then probably the most common one, or at least the one that we identify with the most, and that's the moving joints, the synovial joints. And so in the joints, basically, for lack of a better way to look at it, what you're essentially doing with the joints is you are basically putting them together and kind of linking all the bones together. So we studied all the bones, we're putting them together with ligaments, and now we're going to be essentially kind of putting them together into functional units. And bear with me 1 second, because I realized that what I did was I accidentally grabbed last semester's chapter 8 when I want hours, which is a clean slate. Okay. So first of all, we're going to start off with classification. And there's a couple of different ways you can classify joints, depending on how you look at it. There's a structural classification or a functional classification. For structure, you're going to be taking a look at the way the different joints are basically put together. So we kind of mentioned before, we have what we had in the previous image was mostly a structural type of a designation. So for instance, you have the fibrous joints that we'll be taking a look at, and we'll be looking at examples of fibrous joints. The cartilaginous joints, which we'll also be taking a look at in brief. And then, of course, the synovial joints we'll be taking a much deeper look at. Because let's face it, in most of our careers, for the most part, we're going to be interacting with the synovial joints by far more than any of the other two structural types. And then functional types, which oftentimes we also use as well, because we will oftentimes talk about joints in terms of what they do, their degrees of motion, their range of motion, things like that. And when you take a look at these types of functional designations, you have what's called a synarthrosis, which basically is a joint that doesn't move. It's not designed to move. It's designed to be more structural. You have an amphiarthrosis, which kind of moves a little bit, but still it's not like really something that you're going to be deploying in order to really get good range of motion on. And then, of course, the diarthrosis, which are the freely movable ones. And so, typically speaking, when we work with most joints, what we're usually working with are diarthrotic synovial jointed joints. And so they tend to be the movable ones, the ones that we blow out when we're skiing or when we're snowboarding or something like that. These are typically the synovial diarthrotic joints that we usually is the subject of the orthopedics field. So let's take a look first of all at the structural so that we know how different joints are put together and how we can deploy these different structures to achieve a particular function. Starting with, first of all, with the fibrous joints. The fibrous joints are so called because you might have guessed, because they're basically united or they're sealed together with fibrous connective tissue, where we talked a little bit about loose connective tissue, fibrous connective tissue. They don't have a cavity. So there's no like cavity or space. It's basically a solid piece. And so it's a pretty solid connection. You're not going for movement on this one. And so the types of fibrous joints that you see are sutures, which you guys saw in the skeletal system. And you can see how those are types of joints that are not designed to move. You don't want your parietal bone to be rubbing up against your frontal bone or moving at all. So you want those things to kind of stay locked together. A syndesmosis, which we'll take a look at an example of a syndesmosis here in just a second. And then a gomphoses, and this is basically a very specific type of joint that we'll take a look at. So here's how the sutures basically work. So during development, generally speaking, as the periosteum of one bone grows the bone toward another, basically when you are a fetus, your parietal bone, for instance, is spreading out in all directions and slowly kind of proceeding and moving toward the other parietal bone. And then when those two parietal bones hit and they get together, they have to suture themselves up or they have to join themselves together. And so what happens is the periosteum of one bone basically kind of sutures together with the periosteum of the other. That basically means they weave together. And kind of this woven structure, and that's kind of what a suture looks like. And so if you look at it closely, you'd have to kind of get really in there, like a microscopic type of an inspection of the sutural joint itself. You'll notice that in there, you're going to see a couple of different features. For instance, a sutural ligament will have your two periostea, so that is to say the two periosteal liners that are kind of sutured or woven together. And then in addition to that, you'll see dense fibrous connective tissue in between them. Very similar to what we talked about before with how you use that kind of collagenous fibrous layer of the periosteum to sort of weave into the collagen, the collagenous fibers of a tendon. Using the very similar sort of a thing, you're using in this case those dense fibrous fibers to interweave between the two periosteal liners. And so that kind of is essentially the ligament of sorts, if you will. So essentially two bones joined together, woven together through their periostea, through these fibrous connective tissue strands that are in the periosteum. Now, when you have a suture that gets pretty much like solidly filled in, they ossify completely, then we refer to it as a synostosis. And we don't have a whole lot of them. There's actually one in the temporal bone. It's like basically it's like a suture that basically comes together, and instead of being like the sutural ligament where you have kind of an interweaving of the periostea, you have really bony matrix that gets laid down, and it essentially just sort of blends into each other, and it kind of creates just one bone, and so you can't really see it that well. And so there's one kind of like right in the middle of your forehead because embryologically your frontal bone comes together from two pieces, but it's just so woven together, it's so sutured together that it's pretty much just all bone instead of having these ligaments there. And then, of course, when you're born, you have your fontanelles, which are essentially the membranous areas where the bones or the ossification area has not fully completely filled in the area. And so the coronal sutures and the sagittal sutures and the lambdoid sutures are still largely soft and membranous. They haven't fully ossified yet. And the reason why you have this is so that the baby's head can distort as it's being born. It's the only way that you're going to be able to get that big old baby head through the birth canal without killing the mother. And that's the reason why you have that, so that those bones can sort of crush a little bit and kind of distort and then kind of work its way through the birth canal. It also, the nervous system of the baby is also growing rapidly. It's actually one of the major systems after birth that's developing in the years of 0 to 5 years old. And so that brain is getting bigger and bigger and bigger. And that basically allows kind of room to grow. So that's kind of what the fontanelle is like. And this is kind of what the side view is. So you can see there's basically kind of incomplete ossification of the major skull bones, not all of them. Like for instance, the face, the bones of the face, maxilla, zygomatic, nasal, things like that. Those are mostly together. The real soft areas you see are between the major bones, in particular the four major ones: parietal, frontal, temporal, and occipital. And that's basically what creates kind of those main soft areas. Okay. So still working on fibrous joints. We're going to be taking a look now at the syndesmoses. So the syndesmoses basically are a situation where you have a ligament that kind of joins two bones together in sort of a working whole, right? So this is basically two bones are bound together working as a unit. The best example of this is the radius and the ulna. So you can't suture them together because they're too far apart. So what you do is you use this connective tissue sheet, in this case called the interosseous membrane. So you have this large sheet of connective tissue that connects the ulna to the radius, and that kind of binds the two up. And then you have a couple of other major ligaments, for instance, the oblique cord, which ties the ulna to the radius, and another annular ligament that wraps around the head of the radius and ties to the radial notch of the ulna. And that binds also the radius to the ulna together. And so what this does is it basically creates the interosseous or the radial ulnar joint, where you basically have the radius and the ulna working together. This is a radial ulnar syndesmosis. And so when these two guys move, they basically twist together. For instance, when you turn your arm, your radius and your ulna cross over each other, and they're kind of held together by this interosseous membrane. So that's kind of a special type of jointing where two bones are joined together in a type of a joint that's designed for them to work together as a unit. And so what this does is, instead of creating a situation like your humerus, right? Your humerus is just one bone in your upper arm. And it gives you good strength, that's for sure. But you could have done the same thing in your lower arm. You could have made just like one bone. But the problem is, if you had just made just one bone, your range of motion of your forearm would have been completely diminished. You can't, for instance, twist your entire arm the way we can. We can basically do a 180 degree, and actually more than 180 degree twist of our hand, almost, not quite, but almost a 360. It's like about a 240 or something like that. So we can twist it from the supine position of the hand, twist it all the way to prone, and we can keep going to where it's almost twisted all the way back around. And that's because we have this kind of dual bone situation in our forearm. If we had just one bone there, we would not get that kind of twisting motion in our forearm, and we would not be able to have quite the same ability, the range of motion in our hand, where we could have a very supine or very prone type of a situation. That gives us a lot of dexterity in our ligaments, or excuse me, in our limbs. That really does benefit us greatly. Most animals don't have that type of range of motion. If you want to take a look at it in comparison to another similar duo, take a look at the tibia fibula duo, right? I mean, here's a one where the tibia and the fibula are also kind of bound together, tethered together. But because the tibia is so much more dominant than the fibula, you don't have that same kind of twisting range of motion of your foot. You can't really twist your foot backwards so that it's completely 180 degrees pointing behind you. And that's because of that loss of range of motion. So this does give you a good range of motion that helps you out a lot. The gomphoses, which is the last of the fibrous joints, is a specialized area. And so this is essentially where the periodontal ligaments hold your teeth in place along the bone of the alveolar margin. And so the periodontal ligaments, when you take a look at the tooth, you'll see the crown of the tooth where you have your enamel, then you have your dentin, and then your pulp is in the middle where you have your vasculature and your nerves. And then the roots basically go down into this bony pocket into the alveolar margin where the blood vessels and the nerves enter. But around that, what's holding your root into the actual bone, either of your mandible or your maxilla, are all these little ligaments that are basically tethered to the outside of the root and then bound to the bony structure of either your mandible or your maxilla. And this is underneath your gum line. And so the gum line is a soft tissue, covers all of this. And those ligaments are basically what holds your tooth in place. And so that particular type of connection, that is to say, the bone, if you will, of your tooth, for lack of a better term, to the bone of your mandible, your maxilla, is a type of joint. It's the gomphoses. And so this is a major part. So if you have deterioration, for instance, of your bony material, then you're going to lose that connection. Those ligaments are going to break down and your tooth is going to fall out. So that was for all you dental hygienists there. Okay. So let's go ahead and then take a look at the next piece. So we had the fibrous joints, and now we're going to have the cartilaginous joints. So the cartilaginous joint is going to be broken up into two different pieces. And so the way you define a cartilaginous joint is different from a fibrous type of a joint, is that these joints typically have the two bones involved, and that's certainly true. But generally speaking, they're united together with a piece of cartilage. So there's a little bit of a cartilage plug that kind of connects the two bones together. So you have two different types of cartilaginous joints. You have what's called a synchondrosis. Basically, these are hyaline cartilage types of joints. And then you have a symphysis. That's a fiber cartilage joint, that white fiber cartilage, that tough, very strong type of cartilage. And so when you see a joint that's joined by hyaline cartilage, normally speaking, you're not going to have a lot of movement, right? Because cartilage is a supportive tissue. It's not designed to be mobile. So some of these joints, technically speaking, whenever you have a piece of cartilage joining two bones, it's considered a synchondrosis. But some of these will be replaced by bone, in which case it becomes a synostosis. An example of that is your epiphyseal line, right? So basically the epiphyseal plate here, which is normally a plug of cartilage connecting, you could think of it as two bones. It's not technically two bones, but it's kind of like two bones, right? You got the spongy bone of the epiphysis connected to the spongy bone of the diaphysis, held together by this little plug of hyaline cartilage. And so that's kind of like a synchondrosis. And then eventually what's going to happen is that's going to fill in with bone. So it becomes a synostosis. So really the epiphyseal line is a type of synostosis. But a lot of these are permanent, at least the ones we think of are permanent. So for instance, the costochondral joints, but the intercostal cartilage are types of permanent synchondroses. For instance, when you take a look at the ribs, you'll see the ribs basically come in, but they don't actually connect to the sternum. The sternum actually is connected to the ribs by a little plug of costal cartilage. And this is true for most of your true ribs. Your true ribs will come in, and what will happen is they'll be connected by this costal cartilage. And so these are a type of synchondrosis. And it's designed, the reason why you have this is there because it provides flexibility. To open your rib cage during breathing. So that's why you have that costal cartilage. Remember, costal cartilage, hyaline cartilage in general, is more flexible as a support tissue. And so this will allow you to be able to expand your rib cage as your lungs fill up with air, giving your rib cage this kind of flexibility to expand and contract. When you take a look at the acetabulum, there's a couple of synchondroses here. You'll see the acetabulum is actually constructed by multiple bones, right? For instance, you'll find the ilium coming into the acetabulum. You'll find the pubic bone coming into the acetabulum and the ischium coming into the acetabulum. All of those have a little bit of hyaline cartilage, fiber cartilage in there that basically separates those bones. That is a type of synchondrosis. And that's basically how the acetabulum is formed. And then, of course, that symphysis plug between the two pubic bones is white fiber cartilage. So that is also a synchondrosis. So you can see that typically a synchondrosis can be found anywhere for a couple of different reasons, right? So for instance, the synchondrosis in your femur is a different function than the synchondrosis in your acetabulum, which is a little bit different than the synchondrosis in your pubic symphysis, which is a little bit different than the synchondrosis in your rib cage. So you can see you have the same basic idea, but they all are there for slightly different reasons. Their ultimate function varies a little bit. So that kind of gets us to the symphysis, right, which we already kind of teased out. That's the last piece. So you're, again, fiber cartilage in this case instead of hyaline cartilage, fusing your two bones together. And so this kind of makes things a little bit movable, and so allows kind of a little bit of flex of the pubic bones without the pubic bones colliding together. So you'll see the pubic symphysis between the two pubic bones. You'll also see between the manubrium and the body of the sternum, as those two kind of expand and contract and clash together as the chest expands. And of course, intervertebral discs, as you take a step, are basically patting one vertebra from the other so that you don't get vertebral clashing on vertebra, in which case that'd be very, very painful. Okay, so those are the fibrous joints. Then we had the cartilaginous joints, and now we have the third of the last of the structural types, and that's the synovial joints. Now, the synovial joints are basically defined as a joint that will contain, and so named after, the production of synovial fluid in the joint itself. And so these are joint movement. So movement is the name of the game for the synovial joints, and this is their primary function. So most of your appendicular skeleton is going to be connected together by synovial joints. So for instance, when you're talking about your radius and some of your ulna being connected to your femur, you're talking about a synovial joint. When you're talking about your knee, it's a synovial joint. So all these different types of moving joints are shoulder joints, and for instance, are all synovial because they're all intended to be mobile and to move your appendicular skeleton around. And so they're a very different focus. They're very focused on that movement. So let's take a look at the construction of the synovial joints. We want to take a bit of a deeper look at the synovial joints because, as I said before, those of you who find your way into an orthopedics office, a good chunk of what you're going to see walking through the door are going to be some sort of an injury to synovial joints, right? Whether you're blown out an elbow or it's a shoulder or it's a knee, which probably accommodates a good chunk of most of the cases in orthopedics. Those are all synovial joints. So what do we have in the synovial joints? This is your parts list. So the first thing we're going to see in your synovial joints is you're going to have articular cartilage, which we mentioned before, right? So that's that smooth hyaline cartilage that covers the surface of the bone in the joint. And then the other thing about the synovial joints is that they're also typified by the joint cavity, the synovial cavity, which basically encloses the joint itself, creating the capsule. So the capsule is basically bounded in this joint cavity. And so within the capsule or part of the capsule, you're going to have, first of all, a tough outer layer. So you're going to have a fibrous capsule, which is an outer portion. Typically, it's connective tissue. So you have dense, irregular connective tissue. And this is going to be continuous with the periosteum. So this makes a lot of sense, right? Because basically what that means is the fibrous capsule grows out of, if you will, for lack of a better term, the periosteum as it covers, in this case, we'll use the knee as an example, as it covers the knee. So really the fibrous capsule kind of emerges from the periosteum and kind of forms that tough connective tissue outer portion that encapsulate the entire knee joint. And so different portions of this, because you're talking about a connective tissue outer layer in the periosteum, they may get thicker in order to form ligaments that will connect some of the major large bones together. And so that's going to be your outer layer. The inner layer is going to be what's called the synovial membrane. And so this is basically a membrane that's going to be inside the capsule, except where it articulates to the articular cartilage. So it's going to be mostly in between the open space. And it's typically thin, it's delicate, it's oftentimes cellular. By the way, are you starting to pick up on a pattern here? This has been more than a few times now where we've had the same pattern of having a connective tissue structural outer layer with a cellular physiological inner layer underneath. So it's a common sort of a theme. And so every now and then, depending on the joint, and different joints have a slightly different, version of some of the structure. You can actually separate the synovial membrane from the capsule and fill the space in between them with areolar. Remember, this is that loose fill, that non-structural loose fill connective tissue, and sometimes fat as well. And that will kind of fill in underneath the capsule. So what this does is it basically creates an extra layer of protection. So remember, fat is loose connective tissue. Areolar is also loose connective tissue. So in this case, you have a couple of pieces of layers of loose connective tissue filling in between that dense irregular connective tissue of the surface, the fibrous capsule. And that's good if you have a lot of wear and tear or chafing or strain associated with that. So we'll see some examples of some of those sort of little tricks that we see here in just a second. But the important thing about the synovial membrane is its job is to secrete synovial fluid. And so synovial fluid is basically a mixture of stuff, so polysaccharides, proteins, fat, and some cells, hyaluronic acid. Basically, this should sound familiar to you. Very similar to ground substance. Remember we were talking about ground substance? We said it had all these polysaccharides in it, polysaccharide protein molecules in it, had hyaluronic acid in it, which creates kind of the slippery, kind of lubricating type of a texture. Well, basically, that's what synovial fluid is. It's a slippery kind of type of a fluid that looks very similar to the way ground substance looks. And so this creates a lot of lubrication in the joint itself. Generally speaking, however, there's no blood vessels, remember, or nerves in your cartilage. We already went over that one when we went through the cartilage section. It's avascular and aneural. And so the nutrients then, in order to feed these cells, have to diffuse from nearby blood vessels and they have to infiltrate the synovial fluid. So the synovial fluid does a couple of things, right? Basically lubricates the joint, and provides nutrients to the living cells. So without that, then those cells wouldn't have any nutrients, and basically you wouldn't have the structure of the joint quite the way we have it. Also, nerves in the capsule, which is important, communicates with the brain to help you know the position of joints. And that's one of the types of reception that you get from your body, something called proprioception. It's the ability of your body to be self-aware, right? To be able to be aware of what's going on in your joint. And some of these are conscious awareness, some of these are unconscious awareness, but it's your brain being able to kind of reference itself, its own structures, and knowing where the body is and the parts of the body are in three-dimensional space, the positions of these joints, so it knows how to act. So here's our basic knee joint. They're just trying to be generic here, bone on bone, but clearly what we're looking at is probably more like a knee. And so you can see that as you have your periosteum, your fibrous connection of your periosteum coming in to the outer layer of the bone, from that, you're going to get the extension of the membrane. So the outer layer of the periosteum becomes that tough joint capsule, and then the inner layer basically morphs into the membrane, the synovial membrane, which you can see here in blue. And so just underneath the capsule, you'll see the synovial membrane enclosing the entirety of the joint cavity. So you have basically this joint cavity that then gets filled with synovial fluid, this lubricating fluid. And then in addition to that, you're going to have your articular cartilage surrounding your bone that's greased up with the synovial fluid, which is bathing the surface of the articular cartilage. And then that's going to be basically kind of greasing things and making sure to reduce friction. So this is going to reduce a lot of friction. In your joint itself. And then you can see that your periosteum can basically grow into a tendon sheath to connect muscles also to this area. And then you can also allow for some vasculature to be able to diffuse nutrients into the synovial fluid to nourish the cells that need to be nourished in the joint capsule itself, in the joint cavity. So that's your main piece, right? So that's your kind of like your main list. of your synovial joint. Now, some accessory structures. So not all synovial joints have this. Some will have some. One in particular, the knee, has pretty much all of them. But different synovial joints, depending on their size, location, or load that they have to deal with, will have different mixes of these accessory structures. So let's take a look at the accessory structures and see what we've got. The first one to go right into is the bursa. So the bursa are basically little pockets of the synovial membrane that are fluid filled typically, and they extend out from the joint itself. And their job is to create like a little pad to reduce friction. So in high friction areas, you'll see a bursa kind of tucked in there to basically kind of reduce friction. It's kind of like putting like one of those little pads on your toe when you have a lot of friction in your shoes from your toe. You put a little pad on there to kind of reduce the friction. Bursitis is basically an inflammation of the bursa. And so it tends to be very painful, very sensitive. Of course, ligaments and tendons will help to stabilize the joint. So these will basically stabilize the joint itself. If they're injured, they will destabilize the joint. Anybody who's blown out their knee or damaged any of the ligaments in their knee knows that their knee will start bending in ways it's not supposed to be bending because they've damaged a ligament in there and it's no longer stabilizing the knee joint. The other thing you also have is articular discs. So in different types of joints, you'll find them. You'll find them in the temporomandibular joint. This is the joint that connects the temporal bone to the mandible. Sternoclavicular is basically the connection between your sternum and your clavicle, where your clavicle meets the sternum. And then your acromioclavicular is the acromial end of the clavicle. So there's articular discs in there that will basically help to connect those together. And then, of course, you have a meniscus, which is a piece of fiber cartilage. It's a fiber cartilage pad, often in the knee. And this basically is purely a shock absorber. It's designed for basically it's designed to absorb punishment. That's what it's designed to do. The fiber cartilage in between your discs, it's designed to basically absorb that shock every time you take a step. And then, of course, you have tendon sheaths, which are essentially little synovial sacs that surround the tendons as they pass near or over the bone itself. So let's go ahead and take a look at some of this and see if we can find any of these structures here. Take a good look at it. So this is basically going to be our knee joint. And so you can see there's a couple of different things going on here. We've taken the femur, we've cut the quadriceps femoris, which is the main muscle, the center muscle of your quad group. And so you can see the tendon of the quads that basically wrap over the knee. They go over the patella, and then they connect to the tibia. And then if you take away the connective tissue associated with that, then you'll see different views of this. So let's go ahead and take a look at the anterior view. We take a look at it. So when you take a look at this, you can see that we just sort of stripped it down to just the bottom part of the femur, just for sake of simplicity. So you can see here's the medial condyle of your femur. This is going to be the lateral condyle of your femur. What I want to show you here is the ligaments that are connecting between the femur and the tibia. For instance, one that we're going to see here is this little guy right here. This little S-shaped like one goes up underneath and connects to the top portion of the tibia to the bottom portion of the femur. This is the ACL, the notorious ACL, the anterior cruciate ligament. So it's basically one ligament that's connecting the femur to the tibia itself. Running in the diagonal along that, so it's kind of moving downward like this, is going to be the posterior cruciate ligament, or the PCL. So we're looking at the anterior view. So the anterior is going to be on the top, posterior is going to be on the back. And then underneath that, going side to side here, is going to be this lateral. First of all, you're going to have a transverse ligament, but then underneath that is going to be this kind of piece of fiber cartilage, little plugs. Those are the menisci. The medial meniscus is this guy, and the lateral meniscus is this one here. So you can see that basically you kind of have your knee tied together and wrapped together pretty well. There's two more, however, ligaments that I want to point out. Connecting the femur on the outside to the tibia, or excuse me, the fibula, is this ligament right here. This is called the lateral, or the fibular collateral ligament. So the LCL. And so it's connecting the femur to the tibia. On the other side, you also have another connecting collateral ligament from the tibia to the femur. This one is the medial collateral ligament, or the MCL. So the reason why these are important is because when you basically hit your knee and you basically take a blow from the side, let's say for instance you're a quarterback and a defensive tackle hits you from the lateral side, right? Because the medial side is protected by the core of your body. So the direction you're probably going to take on the blow is not going to be from the lateral side, but probably more likely from the lateral side. So not the medial side, the lateral side, because that's the exposed side. That's where the defensive tackle is going to grab you, is on your lateral side. When that happens, it's going to cause your knee to buckle inward. So that lateral ligament is going to slacken, but that medial ligament is going to stretch and snap. So because you're basically bending your bone in this direction, it causes your MCL to stretch and tear. This is the reason why a lateral blow to the knee creates immediate lateral ligament damage. Now, if you take a look at it and flip it around to the posterior view, then what we're going to see is, so this is the back side. So now we're going to see much clearer. You're going to see the posterior meniscofemoral. So you can see this guy right here is connected to the femur. Going to wrap around to the meniscus, the lateral meniscus. And that's going to connect the meniscus to the femur. That's why it's called the meniscofemoral ligament. Underneath, you're going to see the posterior cruciate ligament that's connected to the backside of the tibia. And then, of course, you can see the anterior cruciate ligament you can see here that's connected to the lateral condyle and then goes around front to connect to the tibia. And so from this direction, you can see very clearly these pad-like medial and lateral meniscus structures in your knee. So these are basically the kind of the major ones. These are the ones that you tend to injure, that you hear about athletes injuring all the time. And so this is kind of what your knee looks like. This is, I think, a view of a, I don't know if this is a model or if this is a real knee. Could be a real knee with some preserved tendons in it. But here's your medial collateral, your MCL. Here's your LCL. This is your lateral meniscus right here, medial meniscus. Your anterior cruciate comes out in front. Posterior cruciate ligament is in the back, coming that way. When you look at it on the side, you can see the structure of the knee itself. So the meniscus looks like a little wedge of connective tissue in there. And then you see your articular cartilage, this little blue line right there. And then the dark blue is going to be the synovial space, the synovial cavity. But notice what happens is you have some bursa in here. And this is the reason why I like this image, because it shows you where the bursa is and how they're used. So first of all, you notice this little sac right here. That's going to be the infrapatellar bursa. That's to basically reduce friction of your patellar ligament, which is the one that you tap on when you do your knee reflex. And so this is going to create a little bit of pad between that ligament and the top of your femur here, so they're not basically creating too much friction. You have a fat pad in here. This is also to reduce friction and produce padding. Between your quadriceps femoris tendon up here and your femur, you have another bursa that basically keeps those two from rubbing against each other and creating a lot of pain. And then on top of your patella, as your quadriceps tendon goes over your patella and wraps around, you'll have another bursa, a little flat sac that basically protects the patella, the ligament that's going over the patella, from the overhead tissue being chafed on. So it kind of gives you an extra layer of protection and padding. So this is basically like your knee is heavily padded. It's tied together with connective tissue, and it's heavily padded to reduce friction. There's a lot going on in the knee. It's a very complicated joint. Okay, before we move on, that's the synovial joint, by the way, which is like the poster boy of joints. So questions. How do you guys feel about the joints so far? Is everything making sense? You guys starting to think about going into orthopedics now?
Nope.
I love it. Honesty. The good thing about orthopedics, if you do like this sort of thing, is there's a lot of money in orthopedics. Because, well, athletes injure themselves a lot and they need good orthopedics to put themselves back together. So typically speaking, you're paid well. So if you're going to be a doctor, think about orthopedics. It's very mechanical too. Joints are really cool because they're very mechanical. It's like putting together a puzzle. Okay, now let's take a look at the different types of synovial joints. So not all synovial joints are the same, right? It basically depends on their movement. And so oftentimes we'll describe them and classify synovial joints by the way that they move. So the first group that we see are what's called the uniaxial synovial joints. These basically are only going to be moving around one axis. And remember, we're talking about axis. We're talking about like the X, Y, Z axis. Okay, so that's what we're talking about. So if you're only moving along one of those axes, then you're uniaxial. If you can move along two of those axes, typically at right angles to each other, then you're biaxial. If you're multi-axial, then typically you can move in several directions, both the X, Y, and Z directions. So let's look at some examples. The best way to understand how these work is to just look at examples of them. So the first one we're going to be taking a look at is the plane, right? The plane type. So we have plane types of joints. We have saddles, we have hinges, we have pivots, ball and socket, and ellipsoid in nature. So let's take a look at the planes first. So the planes basically, so this is kind of like the range of motion cartoon. And so it kind of just shows you how they move. They basically kind of move in all directions or in one direction, and they just kind of glide against each other a little bit. So those are kind of like the plane types on a single plane. So a good example of that is the articular processes of adjacent vertebrae. Those will kind of slide back and forth very slightly in a uniaxial sort of way. There's other types of carpals, for instance, will move in this fashion. So those are a plane type of joint, the intercarpal movements, the tarsal movements, the intertarsal movements. So the tarsal bones, the way they move are relative to each other. As you bend your foot, basically they're moving in a uniaxial plane type of a scenario. And so there's several different types of those. Usually it's very slight. Notice the common term here. All of these are one direction, but they're slight, right? So typically you're not getting a lot of motion out of any one plane joint. You usually have to have a series of them together. The saddle joints are a little bit different. So it's essentially where you can kind of pivot and rotate. So for instance, this top one can roll in kind of this direction like this. And then this bottom one can do the opposite. It can basically roll underneath it in this direction like that. So that's kind of like a saddle type of a joint. And so, for instance, the carpal metacarpal of the thumb, where the pollex is, this will be like a biaxial type of a movement. Where you have the sternoclavicular attachment, you'll have a little bit of a multi-axial action going on there. That's kind of that type of saddle joint. The best example, probably the most common example of a saddle joint is this thumb articulation. This is the most common one that you see. So how about the hinges? The hinges are easy. It's like your elbow, right? So basically these are only going to be moving in one direction. So they're uniaxial in nature. And so the elbow is the biggest one, right? So for instance, this is just, you're kind of moving up and down, and that's pretty much it. So it's a single hinge. Your knee is a hinge. The interphalangeal movements, axials are hinges. And so those are all types of hinge joints. The pivot joints are a little bit different. So this is basically where when you have a pivot, what you have to have is a focal point. So this is like your focal point, and then you have to have a rotation about the focal point. And that creates your pivot. So essentially it's like the radius and the ulna is a perfect example. So you have basically the head of a radius that's essentially wrapped around ligamentously and tied to the radial notch of the ulna. This allows the radius to sort of twist within that. It pivots within that, and that creates a pivot. So this will be the radius and the ulna rotation. Notice the motion is a rotational motion. You're basically spinning, rotating within that little that little wrap, if you will. So that's your pivot. Ball and socket. This one is multi-axial. So basically you're getting a lot of range of motion out of this one. Generally speaking, it's going to be exactly what it says. One portion of it is going to be a three-dimensional socket, and the other part is just basically going to be a ball that moves in all three directions. Within that ball and socket joint. The two major ball socket joints you have is your hip, your femur, and the acetabulum, which is, so the acetabulum is the socket, the head of the femur is the ball, and also your glenohumeral, your shoulder, right, where the head of the humerus is the ball, and your glenoid fossa is the socket. And so that's basically how you're twisting and moving in all three directions. So it gives you maximum range of motion. And so those are important. The last one that we have are the ellipsoid joints. So the ellipsoids are similar to planes in the sense that they can kind of do this sort of back and forth and side to side movement. But the difference is with the ellipsoid is instead of being flat, so with the plane, the two surfaces were flat. So you had one flat surface rubbing against another flat surface, kind of moving back and forth. In the ellipsoid, it's an ellipse. So what happens is you typically have one kind of rounded area and another type of depressed area. So it's more of an ellipsoid. And so it's kind of moving back and forth. Basically, when you take a look at it, the best way to look at it is the atlas and the occipital bone, right? So for instance, when you have the articulating facets of the occipital bone that are kind of slightly poofed out, they're almost like pillow-like, they're slightly raised in nature. And then the superior articulating facets of the atlas are slightly depressed. And so that kind of creates the occipital condyles. So that kind of creates this little ellipsoid kind of look. So instead of being flat, it's kind of got this little kind of ellipse look. It's just slightly depressed. Almost kind of like, if you think about it, sort of like an incomplete ball and socket. It's kind of like a shallower version of a ball and socket joint. Okay, so now let's take a look then, since we have that, the different types of motion. What kinds of motion can we get from this? Well, first of all, there's a couple of different types, right? So there's what's called gliding types of motions, right? So this is like, you see this in plane joints where there's slight movement. They're just kind of rubbing against each other, gliding against each other, if you will. And then there's angular movements, right? This is basically where the angle between the bones change, either more acute or more obtuse. So the angle either increases or it either decreases. And so they typically come in pairs when you take a look at it. So the first pairing that we see is flexion versus extension. So with flexion, basically, this is where your angle gets more acute, right? And extension is where it gets less acute. So you have flexion, extension, you have what's called hyperextension. So this is extension beyond normal extension parameters. Not always an injury thing, right? So it depends on the joint as to whether or not hyperextension is an injury situation or if it just happens to be extra range of motion. So within flexion and extension, you have specific types of flexion and extension. For instance, you have what's called plantar flexion and dorsiflexion. This is basically the movement of your foot. So plantar flexion is a type of angular movement where you're basically moving your foot as you're standing on the toes. Why they call it flexion is because the plantar is underneath the foot itself. And so that's basically what you're doing. Dorsiflexion is going to be pointing your toes toward the shin. That's dorsiflexion. So notice you're pointing. So they're both flexion in this case. And so they're saying plantar flexion because you're pointing toward your plantar. Which is the sole of your foot. Dorsiflexion because you're pointing toward the dorsal. Now, that's plantar flexion and dorsiflexion. But when you just take a look at flexion, just regular flexion and extension, remember, flexion basically is when you're moving and you're making the angle more acute. Like, for instance, the flexion of your arm is when you're pulling your arm upward. Notice you're basically making the angle more acute. Extension is to move it back, where you're making the angle more obtuse. So that's normal flexion extension of the arm. Flexion extension of the knee is the same, right? So when you flex it, notice you're making the angle here more acute. As you extend it all the way straight down, you're making the angle now, which is 180 degrees, more obtuse. For your hand, typically if you are bending your wrist downward, that is flexion. It's almost as it's the same direction as when you're bending up your arm. So if you bend your wrist toward your shoulder, that's flexion, because what's happening is you're flexing your flexors, which are in the lower part of your arm. And extension, you're moving it away from your shoulder, kind of the way Spider-Man does when he tilts his hand down to shoot his web, right? So he shoots his web out here, right? That's what Spider-Man does. So for you Spider-Man fans, you're welcome. This would be extension. Why? Because you're contracting your extensors. In your forearm. And you're going to be learning those extensors and those flexors in the next couple of chapters. Now, the next grouping that we see is abduction versus adduction. This basically is determined by whether you're going away from the body or whether you're going toward the body or the midline. And so with abduction, adduction, so abduction is whenever you're moving away from the midline of the body. So for instance, you start off with your hand by the body. As you go away from the midline, that's abduction. As you bring your arm in toward the midline, that's adduction. Think of it this way. Abduction stands for to abduct or to take away. So if you're going away from the midline, you're abducting your arm, kidnapping and running away with it. That's abduction. When you're bringing it back, you're adding it back from having been taken away. So that's adduction. And then when you take a look at adduction, abduction of your hand, when your hand is together, this is adduction. In this case, the midpoint is the middle of your hand, not the midline of your body. So basically, if your fingers are all gathered together toward the body or toward the midpoint, that's adduction of the fingers. If you spread your fingers out, it's almost as if they're going away. from the midpoint. And so that is abduction because they're moving away from the midpoint of your hand itself. Okay. Now let's take a look at some of the rotational movements. So these are circular types of movements. So we've had gliding, angular, and now we're going to look at circular. Typically with circular movements, we're talking about rotational movements, generally around some sort of an axis. So we have a couple of things. First of all, we have rotation, which is turning around along the axis. We'll take a look at that. So with rotation, you can see if you just take your arm and you just swing your arm in towards you, that's called medial rotation. You're basically rotating your femur, excuse me, your humerus, right? And so it's moving inward medially. If you move your arm outward to the side, that's lateral rotation. So you're basically moving or rotating your humerus basically toward the outside or the lateral side. The other one that we have is pronation and circumduction. So pronation and supination are both types of forearm movements. And so circumduction is basically like drawing a circle in the air without rotating from your elbow. So basically drawing it from not from your elbow, from your shoulder. So it's basically rotation around your shoulder. As if you were drawing a circle in the air. So this is going to be circumduction. So what's happening is you have no twist at your shoulder, at your elbow. Don't rotate that one. No twist at the wrist. Only twist at the shoulder. If you do that, then what's going to happen is you're going to be drawing a giant circle in the air, and that's circumduction. And it's a combination of a lot of things, right? So you're flexing, so it's flexion of some, extension of others, abduction and adduction as you're going away and toward the body. Now that's circumduction. Pronation is when you're twisting. But remember, you can twist at the wrist. And if you point your hand palm down, that's pronation. If you twist it back around at your wrist and it's pointing upward, that's supination. But remember, whenever you're twisting your arm, you have what's called compound rotations. I always like to think of it as the swim move, or if you're throwing like a curveball type of a pitch. Remember, you have twisting at 3 different joints that you can acquire. You have shoulder rotation, which creates circumduction. You have elbow rotation, radius and ulna, basically. It's slight, but it's there. This is slight rotation, either medial or lateral. And then you have wrist rotation. You know, they always say in sports, you know, just give it a little more wrist, put some wrist in it. Wrist rotation, which gives you supination and pronation. If you add all 3 of these together, you create a compound movement. Like a swim move, or a pitch, like a baseball pitch. You combine all 3. So you can get lots of different types of complex, nuanced rotational patterns by using all three of your joints. And if you're pitching, and the reason why I like pitching is because pitching is very biomechanical. If you talk to a good pitcher, they'll talk about the importance of when you're throwing a pitch, not just throwing it, but you have to actually have correct body form. You have to be able to set your pitch up. You have to be able to use your body to get power. You have to be able to twist your arm, create that pitch motion, rotating your shoulder and your elbow and then your wrist for the final delivery in just the perfect ratios to get the exact type of movement you want on the ball. And using all those mechanics together and really tweaking them to the point where you can master them gives you these really, really great pitches. So it's really fascinating to talk to a biomechanics person who's like breaking down pitch mechanics. There's not a lot of it out there in baseball, but it's a really big thing. Nitty-gritty, like how to teach pitching and how to teach somebody to, like, for instance, deliver an inside curve or a white, kind of a wipeout slider, and things like that, kind of how to change your rotational mechanics, not just of your wrist, but of your whole body. So if you put more rotation in your shoulder on your pitch, you're going to get one type of pitch. If you put less rotation in your shoulder and more of it in the final wrist flip, you're going to get a completely different type of pitch. And so these mechanics are really important in terms of creating the nuances of rotation. Okay, there's some special movements. Those are the main ones, right? These are the specialists. Typically, there's only a couple of joints that do this, right? For instance, the elevation and depression is associated with your mouth. So for instance, where did I put that one? It's basically open mouth, closed mouth is what it is. So you elevate the mandible, which would be closed, or you depress the mandible, which would be open. Protraction, retraction, that's this one here. So protraction is when you slide your jaw forward, and then retraction is when you move or slide your jaw backwards. So that's typically associated with your mandibles, particularly your scapula also does that as well. Excursion. Oh, here's elevation depression. In this case, they use the shoulders. So basically shrugging your shoulders, that's elevation. Dropping your shoulders, that's depression. Excursion, you have lateral medial. This is sliding your jaw back and forth, kind of like a cow chewing its cud. So basically in one direction, if you move it to the right, this is the right side here, stage right, here it's going to be lateral excursion. If you move it to the left, that's basically stage left, patient left. That's going to be also lateral excursion. If you return it to the midline, that's medial excursion. So as you're moving it out, that's lateral. As you move it back in, that's medial. And then you move it back to the other side, that's lateral. If you move it back in, that's medial. Opposition, reposition. This is something that your hands are doing. So in opposition, basically it means that your fingers are touching. So you're touching your thumb to your finger. That's the opposable thumb idea. When they're moving away from each other, that's reposition. So opposition is what we're talking about when we talk about the opposable thumb. And then inversion, eversion is the foot. So if you have an inversion of the foot, it's basically where the sole of your foot points inward toward the midline. And eversion is when the sole of your foot points outward toward the midline. midline, away from the midline. There. Sorry about that, guys. And we oftentimes will see this in the way people walk. So sometimes they'll walk with a noticeable inversion where they're kind of walking on the outer edges of their feet, or sometimes they'll walk with a noticeable eversion where they're walking on the inner edge of their feet. And then, of course, we have combination movements, like we mentioned before, the swim move or the pitching move, where there's multiple movements involved. Okay, that's the end of chapter 8. And it also happens to be the end of the class.